Oh, welcome back. Now we will look at mood disorders themselves. And in this lecture, we're going to focus on principally on major depressive disorder, although we will introduce bipolar disorder, but we're going to come back to bipolar disorder in the schizophrenia lecture when we address severe mental illness. Now, on the left, I find this chart from a medieval textbook for physicians very interesting. Uh, in medieval times, there was great belief in the theory of the humors, that was a mixture of yellow and black bile, blood and air, and phlegm and water that determined the balance of a person's personality. And what you see is sort of DSM in the 1300s. So at the far left is a man singing sad songs. That is, he has mild depression. On the bottom left, you have a hypersexual man. On the lower right, you have a phlegmatic, melancholic man who stays in bed all day. And at the upper right, interestingly, you have the hot-blooded, angry man, and you see that that's associated with spousal abuse. So really, this is not that much different from DSM in terms of the classification of mood disorders. The difference is physicians at this era thought it was all due to different levels of liquid within the body, so you had to purge or bleed people. And no self-respecting physician in the 13 to 1700s would be without his devices for bleeding patients, as you can see there, and thus restore the balance of the humors. We struggle with our theories of mood disorders to this day. Now let's kind of do a quick overview of where we've been so far. So if we look at the middle box, we have the salience network, which is really going to involve the dorsal ACC, and an area that we're now going to bring on the rostral ACC. We've got the amygdala and insula, both getting external and internal stimuli, but the insula being more interiorly organized. We've got executive control related to both the orbitofrontal, the rewards and punishments, the emotional control, and the central executive, which is the cognitive control. And all of that needs interaction with the default mode network, where it interacts with the Pepez circuit, which really involves our ability to remember the past, construct the world, put it in some kind of context. And as we argued in the last lecture, we're kind of looking at this more in terms of Barrett's constructed emotion theory. That is, we have an internal state, we have memories of the past, and then we have the events in front of us, and the brain puts those together, and then the emotion is produced. And that emotion is either adaptive or maladaptive. All right, so let's start with major depressive disorder. And of course, as you know, it is highly comorbid with many other conditions, including substance use disorders that we talked about last week, and PTSD that we'll talk about next week. When we look at MDD, the structural changes in the cortex are relatively modest. They tend to be in the temporal lobe as well as in parts, the posterior cingulate cortex and orbitofrontal areas, so that's intriguing. This study, I have the abstract here for you to read, looks at a meta-analysis of many different types of studies that have tried to look at particular what areas of the brain are involved in major depressive disorder. And really this upper circle is what they found, and that basically they find that there's this activation of the subgenual cingulate that, more importantly, that tends to predict good response to an antidepressant treatment. So if you're among the people with MDD that the subgenual cingulate is increased in functioning, you're somewhat more likely to respond to an oral antidepressant. Now, you generally speaking, You get decreased hippocampal volume in people with depression, and that's also true with the severe anxiety disorders, particularly PTSD. And you tend to get hyperactivation of the amygdala. And then I'll really, those are really the key areas. You can read about the lower row at your leisure. But we're really thinking of this in terms of something in the salience network, the regulatory mood circuit is off, something in the hippocampus as a node for depressive disorders, and of course, again, the amygdala part of the salience network. Now, when we look at our network theories, we are starting to work off what we call the tripartite theory, the tripartite network. And here the model is done for PTSD, which we're going to delve into in depth next week, but really applies to any of the internalizing disorders. That is, disorders manifest by feeling bad internally, sad, anxious, upset. And what you can see, what the hypothesis is that in the salience network, if this is overactivated, we get heightened threat detection, and this impaired default mode network and executive network modulation. Remember, we talked about the salience network governing that anti-correlation between the two networks. Well, maybe in the salience network, it's getting too much from the internal body, and it's forcing the default mode network to be on too much and overly internally focused. Obviously, the central executive network, it can be decreased, and that is related to the long-standing study that people with major depression often have executive function deficits. Now, here the default mode network, it speaks of, here it's doing it specifically for PTSD. So in the prior lecture, we talked about the default mode network having a normative but quantitatively excessive internal focus. Here they're arguing that in PTSD, the intrinsic action of the default mode network is the internal focus is you get the altered sense of self, and these memories of the past come flooding in much too vividly. It's not just a matter of comparing the past to what's going on now. More about that next week. All right. So we've gone for a long time trying to figure out depression by seeing what treatment does for it. And interestingly, ECT has a remarkably broad range of therapeutic effects. So what you're seeing on the left are those areas of the brain where ECT leads to an enhancement of gray matter. And interestingly, the dorsal medial prefrontal cortex, that's one area that is particularly positively affected by ECT. On the right, we see a number of findings, all of which tend to normalize the functioning of either the brain or the body. So we see decreases in 5-HT2 receptor binding, increases in blood-brain derived neurotrophic factor, and we talked about its role in neurogenesis. We see decreases in the inflammatory factors. We see increases in the hippocampus, because after all, one of the main findings in major depressive disorder is decreased hippocampal volume, and various other improvements in functional changes in the brain, particularly changes in the resting state networks. All right? So apart from the encouraging our patients to have ECT, this is all very useful data, as well as refuting myths about ECT. Now, but how about oral antidepressants themselves? Well, a little history here. Antidepressants were discovered because in the 1950s, anti-tuberculosis drugs were found to have mood-enhancing properties. You know, people dying of TB were saying, I don't feel so bad after I take this drug, even though it wasn't necessarily helping the TB. And it was found that these anti-tubercular drugs inhibited monoamine oxidase, prevent the breakdown of norepinephrine and serotonin. By coincidence, around the same time, an antihypertensive named reserpine was developed, and it was found it depletes norepinephrine, and it was discovered that severe depression was a side effect. So that led to the monoamine hypothesis of depression, which is depression is caused by too little norepinephrine or too little serotonin. And the first antidepressants were mixed, the tricyclics were mixed serotonin and norepinephrine reuptake inhibitors. People thought, well, it would be great if we could just have pure neurotransmitter reuptake inhibitors, and that led to the development of the SSRIs. Now, when early studies of SSRIs were done in the 70s and 80s, culminating in their approval in the early 90s, we used to get big effects. 66% of people in the active drug group and only 30 to 40% of people placebo. And then as time has gone on, the placebo response has increased. And as a result, when you do meta-analysis, people often say, well, the drug placebo difference is only about 0.3, and that's pretty small when you consider, say, stimulants and ADHD are like 0.8, 0.0. But the problem is those studies now mix three groups of people. The placebo responders, the excellent responders to the drug, and people who are non-responders. So really you're getting an average with a huge amount of variation. And on average, the norepinephrine serotonin reuptake inhibitors might actually be mildly more efficacious, but they have more side effects. Thus the standard protocol now that we start people on an SSRI. Now, here is a chart you've probably seen many times, mechanisms of the SSRI, and I refer to it as a totem. And you say, well, Dr. Plisko, what the hell is a totem? Well, a totem is a set of beliefs, usually a mythical set of beliefs that a group of people use to explain things around them. It's usually used in the context of explaining the belief systems of people in the underdeveloped world. But Sigmund Freud wrote his famous book Totem and Taboo about how belief systems govern people's behaviors and where they come from. The reason I say that is because I won't say that this information is not useful. It is useful in terms of sometimes predicting side effect profiles, but it's not telling us as much as we would like about the mechanisms of why they work in depression. So let's take reuptake. As you know, escitalopram is the most potent reuptake inhibitor. You see that it's 10 times more than sertraline. What does that mean? That means you give 5 milligrams of Lexapro, and that's the equivalent of 200 milligrams of sertraline. Sometimes people come in the clinic and say, well, sertraline didn't work. Well, how much you take? 50. Well, that's the reason. Got to keep in mind how you use the potency figures. But you don't have to block the reuptake of serotonin at all to be effective. You can see that with Remeron there at the bottom. Similarly, they have all these other agonist actions and they have all these antagonist actions. And, what does it mean? Now, if we say, well, I think this particular patient really needs alpha-2 antagonist mechanism, so I want to give them Remeron, or I need a sigma-1 potent agonist action, so let me do Luvox. I'll bet you didn't know Luvox was a potent sigma-1 agonist, but it is. It really has not helped us to the degree that we can. And we knew that from the beginning, because in the days of tricyclics, we knew these things block the reuptake right away, but it takes weeks for people to fully respond. All right. So in the book, in page 224 of the text, I go over what is now the general belief about what the central medication mechanism is. So yes, we block the reuptake of norepinephrine. Yes, we block the reuptake of serotonin. And we may do all these other receptor things. They may or may not contribute. But we'll have these immediate effects on cyclic AMP and protein kinase A, but ultimately we get activation of transcriptions, production of BDF in particular, but that will stimulate our TRK receptors that we talked about in the earlier lectures and will activate a whole series of internal enzymes. PI3K, which we talked about in the earlier lecture, that will inhibit the so-called apoptotic enzymes, those that kill neurons. Now, you need these neurons to keep yourself, you need these enzymes, these Death Star enzymes they keep you from getting cancer because they make sure cells die in an orderly way. But if you're losing neurons because of major depressive disorder or severe PTSD, then they're not your friend. And these enzymes are inhibited by PI3K. If you don't know, you're saying, oh, I forgot what PI3K is, go back to the first lecture or that chapter of the book and you'll quickly be able to review. Of course, high degrees of stress, cortisol, will activate a whole series of these apoptotic enzymes as well. So the entire focus of the last decade has been, oh wait, what can we do to speed this process up? So that has gotten to ketamine. And of course, in psychiatry, we work backwards from the drug that's effective. And the idea here is that both ketamine and psychedelics have a common final pathway in terms of their mechanism of action. And let's take a look at that. So here, up here, we have the NMD. I left the A off here. The NMDA receptors here, both presynaptically and postsynaptically. And over here we have the postsynaptic 5-HT2 receptors. So if we give ketamine, we're blocking the NMDA receptors, and that's going to lead to less GABA here. What's next? Well, if you have less GABA here, the presynaptic neuron will start pumping away. And if you hit the 5-HT2 with a psychedelic, you'll essentially do the same thing. Okay, what next? When you turn this off, then you stop inhibiting eukaryotic elongation factor 2. And all right, great. And then what? Well, that's going to help the AMPA receptors bring more calcium in, and that will lead to more BDNF. And the BDNF in turn will activate mTOR, one of those enzymes in the nucleus that's going to generate all of these amazing anti-apoptotic and pro-neurogenesis enzymes, and you're going to kind of get your synapses starting to recycle. There, left off the last step for you. Okay. Now here's a little more sophisticated diagram, to be honest. That other diagram I did a number of years ago. But it tells you the same thing. Basically, if you give your psychedelics, you are going to activate your IP3, get your calcium going. Over here, we will get your BDNF going, activating the TRKs, and there's our mTOR, and it just fills in the blanks for you. When it gets in here, we get all these cool things going that, as they say, upregulate molecular effectors mediating synaptic growth, remodeling, and circuit reorganization. All good. Now, interesting, this diagram appears in a recent article in Progress in Neuropsychopharmacology and Biological Psychiatry, where it's saying psychedelics in autism. And they're arguing, well, if we just could stimulate that 5-HT2 receptor in autism, boy, the wonderful things are going to happen, because we're going to be remodeling all of those people's synapses. And herein lies a problem. All right. Okay, so great. If we stress rats, that's not good for the rats. And it's not good for synaptic density. So here we see a bunch of dendrites, and you see how shaggy they get under severe stress. And over here is an imaging study in humans, and we're looking at three different brain areas, and here we're looking at severity of, and we're looking at it as a function of severity of MDD or PTSD. And you can see that there is decreased synaptic density, certainly statistically significant, but you got to admit that there's still a lot of overlap with the control group. You know, on the other hand, there aren't in the MDD PTSD groups, there aren't anybody at the top of the stack, so to speak. All right? So, yes, we have evidence that affective disorder reduces synaptic density. Well, so we try to look at, well, let's give some people some ketamine, and here the blue in the top is healthy people, and the orange in the bottom are depressed people, and 24 hours later, we don't see that change in synaptic density in the live brain. Now, in this group, it also looks like the depressed people weren't necessarily lower than the controls. And that was a little disappointing. All right. So recently, ketamine, that's old hat. You know, marijuana, that was going to cure everything. And then we had ketamine. We're getting tired of ketamine. Let's get our psychedelics, man. Let's go there. So psilocybin, I like this study. Literally just came out. And what they did there, now this is healthy subjects, but what they had them do is take 25 milligrams of psilocybin, and they did MRI studies, and they also did electroencephalograph, EEG studies. And they saw them immediately after the day, they assessed them the day they got the psilocybin, and also a month later. So bear in mind, these people are getting just one dose. And interestingly, these normal people did show more cognitive flexibility, more psychological insight, and well-being 1 month later. Now, I am not encouraging you then to go out and do some psilocybin, although that's getting to be a thing, as you surely know. Now, diffuser tensor imaging was done 1 month before and after, and they did axial diffusivity. And remember, high FA is good because your water molecules are shooting down the axon. Axon diffusivity is bad because your molecules they're diffusing everywhere. That's the good way to remember that. All right. So they measured this cool thing called brain entropy. That's kind of a bullshit name for it, but let's go with it. All right. What they do is this is kind of a sort of semi-machine learning thing where they look at the complexity, irregularity, and unpredictability of the EEG waves, or how disordered it is, thus using the word entropy. Now, you should not assume that it's good either way, or sometimes having your brain disordered is good, sometimes it's bad, but it is an interesting measure. So here the 1 milligram of psilocybin kind of serves as a placebo, and you can see there's not really any change in brain entropy, but brain entropy rises on the dose over 4 hours after they've taken the dose. And they here reduced their alpha power, which means the EEG is more activated. I suppose we're not too surprised by that. All right. Now here they look at the after a month, they look at white matter axial diffusivity, higher is worse, remember, and they see some statistically significant but relatively modest changes. The AD goes down, which is good, and over here they're looking at something different called modularity. Modularity is, do you have that hub and spoke system in your neural networks that we talked about in the early lecture? And again, they find, that's not so good. That went down, and the more it went down, the less happy people felt, all right? So a little bit of mixed finding there, which is why, again, we want to be cautious about this stuff. All right. Now, this guy did an interesting study at people with MDD who were not treatment resistant. These are just more clinic level MDD, but they needed some kind of routine surgery where they had to be on general anesthesia. So they said, hey, how'd you mean a study where we either infuse ketamine or we give you placebo while you're asleep, and then we'll see how you feel when you wake up? Everybody said, yeah, sure. They were all depressed going into the surgery, and they all got better. So this study was a bit of a bust. If none of them got better, if they all remained depressed post-surgery, then we'd been a little more excited about it. We would have said, aha, you have to have the psychedelic experience to have a antidepressant response. But we can't say that because it actually was a failed study. People responded to the placebo of being in the hospital, having their operation, maybe fixing their underlying condition. But kudos for trying. All right. Now, this poor company, the Relmada Therapeutics, they developed a drug uh, where it preferentially targets the NMDA receptors, but you get no euphoric effects and no psychedelic effect. But you do get all the other biochemical effects. Interestingly, it did not work. All right. So people don't dissociate, and even though you're kicking up all that BDNF and all that other stuff, they got nothing. So that's a data point to consider. All right. Now, before we go on to TMS, here's a little quick homework assignment besides the quiz, which I will send out. LSD is, of course, one of the psychedelics, and the Beatles song "Lucy in the Sky with Diamonds." Did that refer to LSD? I'm sure you can all look it up on ChatGPT right now, so it's not much of a homework assignment. But I should note that LSD, when I was a teenager, that was like among adults, among parents, school, that was the most feared of all the drugs of abuse. That was the one that would make you go crazy. That's the one that was going to wreck your genes and you'd have mutant children. That's the one that really triggered Richard Nixon's war on drugs. And that probably obviously inhibited the development of the psychotropics as a therapeutic agent. In fact, while you're finding out about the Beatles and Lucy in the Sky with Diamonds, you can also read about Dr. Timothy Leary. So I'll send you this video to watch at your leisure. Fundamentally, what we're doing is that in TMS, we're kind of doing, of course, mini ECT. We're putting a magnetic field over the skull, and so that through the magic of Maxwell's waves, we will induce an electrical field in the brain. And the goal is not necessarily to stimulate the dorsolateral prefrontal cortex, but rather to stimulate it in just such a way that we can activate other brain networks. So what you're seeing here, as I say, is that the activity needs to flow through the networks to the subgenual ACC, which is a key hub for the success. And increasingly, and Peter Fox is one here at our center, one of the pioneers of this, is to do an MRI, a structural MRI, before they do the TMS and use that so that you can target that field more precisely. And thus, the TMS can affect network activity. And the white means areas where we've driven a positive correlation, and black means we've driven a negative correlation. That's more clear in the next slide. So here in these people with depression, what you're looking at is the connections within the salience network are increased, but the connections within the default mode network are decreased. And up here you can see that salience is increased over baseline, and here the default mode network is, excuse me, you want to come down here. I don't know why that's probably a typo there. This actually goes down a bit here. So the idea is that the metabolism levels of the network shift. Maybe you're less internally focused in terms of default mode once that happens. Now, surprisingly, just like ECT, TMS can produce some significant gray matter volume changes. Now, I don't think that was expected, but it's true. And currently, the big thing is the SAINT protocol, where basically you are looking at using a intermittent burst so as to improve the efficiency of the whole process. And here you see some of the results. And while the average data looks great, if you look at the individual scores, you will see that there's a fair amount of individual variability. And in general, in larger TMS samples, you don't always get the great results that are sometimes bragged about. All right. Now, finally, we have deep brain stimulation. The key area that everybody looked at was the subgenual ACC, and here you see the probe is in there, and when you turn on the stimulation, you stimulate not only the subgenual ACC, but the anterior cingulate in general, as well as a lot of prefrontal areas, including the parts of the default mode. And it appears that getting that medial prefrontal stimulation is key. You can see here we had 6 of them, the stimulators here, non-responders here, and 2-year responders, they're still getting that stimulation. Now, the big original trial, which I discuss in the book to look at brain stimulation, it unfortunately failed. And so the kind of work from Dr. Gu came earlier, where they're doing much, rather than just putting a needle in a certain area and turning on the current, looking at areas that respond dynamically to the ventral tegmental area or these other circuits we've talked about. That's the cutting edge in terms of brain stimulation. Now, the big issue in the treatment of depression is that, well, all MDD is defined simply in DSM. 9 symptoms, you got to have them. You got to have depressed for 2 weeks. You're not eating, not disturbances of appetite, sleep, etc. But we all know that that's an incredibly diverse group of people who walk into the clinic any day and say, I'm depressed, and meet criteria for MDD. On one hand, we have the PhD from the anatomy department who comes in, and he's never been depressed in his life, and everything's going great in his life, and he says, Doc, I don't get it. A month ago I started feeling like crap, and I'm so depressed. So the same thing happened to my father, and he took Prozac and he did great. And you're feeling pretty good because you think, well, Prozac's going to help this guy. Versus the other person who grew up in a foster home and they were sexually abused, and they do self-abusive behavior and they want to kill themselves all the time. They had 16 hospital admissions. Are those two things the same? Well, obviously not. But we don't have any, we can define them clinically. And we can say, you know what, I think that guy, that PhD from anatomy, he's more likely to respond to SSRIs. And our borderline patient, particularly if they've got some kind of agitated, hearing some voices now and then, bipolar 2 type stuff, we can say, well, they're probably not likely to respond. But that's not 100%. Not 100% at all, right? So we think there must be deeper down a biological distinction. So just as you can't just say arthritis, there's osteoarthritis and rheumatoid arthritis and arthritis that's associated with lupus and Sjögren's syndrome and so on. There has to be something at a biological level going on. How can we understand that? Well, this study I'm very excited about. I hope you will be too. These folks got 800 patients, and they did a standardized fMRI protocol doing both tasks and resting state. And then about 250 of them were randomized to either get pharmacotherapy or behavioral therapy. And the pharmacotherapy group was further randomized to either get venlafaxine or an SSRI. And then they used machine learning to categorize these people based on their fMRI results into these 6 biotypes. And I'm not going to go into how the machine learning works. I'm just going to show you the results. And oh well, actually I lied. I am going to show you a little bit about the machine learning. So what's different? Normally we used to say, okay, depressed people line up, get in the scanner. Okay, normal people line up, get in the scanner. And then we look at the averages in both groups and we do a traditional statistical analysis. Is our p-value .05. It's not, oh shit. All right, that's where we were 10 years ago. So now we got all these hundreds of scans, and what we do is that each person has a certain pattern on the fMRI. So they're saying this is a person with depression, this is a person with who's not depressed, and then we put all the network scores of the people who are controls down here, depressed up here. We line them all up, and then we use our machine learning, and here we use one called hierarchical clustering. It's one of about 50 machine learning techniques. Learn them all. They find that these statistical techniques group these people into these six conditions. All right. Well, that's great, but do they mean anything? That's the next step. All right, now we're into it. So here are the first 3 biotypes. And what you're seeing here is, so yellow are the attention networks. We learned about those. Green is the salience. You learned about those. And default. Now that you know them, I don't have to tell you what you are. You just know. This is a group of people, where their disturbance is in that 3 set of networks. Now the next group only has dysfunction in the attention network. The next group has dysfunction in the NS negative affect circuit. That is a subset of the salience network, that amygdala insula that we talked about responding to negative stimuli, and also the positive circuit. So this is a group that's maybe it's a more emotionally tied. This is a more cognitively group. We're saying this makes sense, Pliska. I mean, maybe we're getting somewhere. Up here, we've got one where it's, again, just cognitive, predominantly in the frontal lobe. And down here, NTC, negative affect circuit evoked by conscious threat stimuli. That's a little subtype too. So these people, that they're unique in that way. And then we finally have a kind of general group, which is not that different from the controls. So you can't have everything. But we've certainly got these 6 subtypes. Okay, well, does it correlate with anything? Well, these people tended not to respond to cognitive therapy. That's why the circle's open. They're the defaliants with salience, whereas these people that attention hypoconnectivity, you see they have all the cognitive problems here, they did respond to the therapy. Yeah, well, that might make sense. If you're cognitively impaired, maybe cognitive behavioral therapy is just what you need. That's why they call that subtype attention hypoconnectivity. And then they had this group SAD, negative affect, with positive affect hyperactivation. They did equally well on all treatments, but they were characterized by anhedonia and ruminative brooding. And then this group, cognitive control hyperactivation, they had a lot of problems in this area, and they tended not to respond to venlafaxine. That's interesting. And then this group, they were kind of just sad, and these people didn't respond to treatment. And this group was just this is your more similar to control group, more study of that. Now, is this ready to use in the clinic? Not quite yet. But this is where I think the field needs to go, and this is what you guys have got to pay attention to. Because it's possible that we're going to want to individualize treatment based on this sort of thing. Now, if you can add genetics to this, because machine learning isn't limited to one modality. You can put in the imaging, you can put in the genetics, you can put in the past history from the EMR, and the more you put in, the more it can chop around and do all its different support vector machine, and K clusters, and hierarchical clustering, and lasso regression, and all that cool stuff. Which one of these days we got to have a grand rounds on all of that by somebody who knows more about it than I do. You can do all those things, and you can start to come out with stuff that's really meaningful. My argument is psychiatrists need to be the ones speaking that language and doing that work. All right. All right, let's say a few words about bipolar here, and we'll expand on this next week. All right, good old Emil Kraepelin. He is the father of DSM, really. He's the man who made the distinction between schizophrenia, although he called it dementia precox, and manic depressive insanity. Now, we know that Emil did this by, I think I have cards here. No, I don't. Okay, let me go back. Sorry. Let me go back here. Oh, no. Hold on. Sorry. Here we go. We're back. Oh. All right. I'm almost back with you here. Don't go anywhere. All right. He had these cards that he tracked people's moods in their course, and he would collect them on hundreds and hundreds of patients at this institution that he worked at. And then he would sit down and he'd sort them into patterns, and people fit the schizophrenia pattern and people who fit the manic depressive pattern. He said, "Oh, that's how I did that." We had a big pile of cards in the middle. And what did he do with those? Well, later in his life, he talked about, well, maybe things don't break down cleanly into these two groups the way we did. But nonetheless, we have that in DSM. And of course, but we got all this stuff in between. Schizoaffective, all this other stuff. We see over here one of our intrepid chief residents of years past is channeling good old Emlyn. All these distinctions we make in DSM. And here we got the A's of Bueller. It's great. Positive symptoms and so on. Over on the other side is all the neuroleptics and their receptor stuff and that and whatnot. Okay. So we've been doing that now for 100 years. Well, 100 years we've been doing the classification. 50, 60, 70 years we've been doing the receptor stuff. All right. So we're trying to get down to it. So this was the major bipolar GWAS, and they determined that that they predicted that there will be about over 8,000 variants from GWASs that are related to bipolar disorder. Here are some of the they found so far. Here's a calcium channel gene. This is an autoimmune gene, the multihistocompatibility complex. Most of these others are genes involved in neurogenesis. Right now, most of these samples are from Europeans, so they're explaining most of the variants in Europeans, and that's why there's a big push on to really develop samples from all over the world. Now, one great mystery is that bipolar disorder, actually both bipolar disorder and schizophrenia are associated with higher creativity and higher achievements in family members of the affected individual. And sometimes the affected individual themselves is quite talented. But that's not the rule across the board. Sadly, many of our bipolar patients that we admit to the VA or to University Hospital have lots of cognitive impairments and low IQ. Well, interestingly, it's found of these these variants, there are some, those in green, that push the risk toward bipolar, but also are associated with high IQ, whereas the red variants push you toward bipolar, but are associated with low IQ. So that's intriguing, but would explain this paradox that we often run into. Now, I'm really going to hammer on this in the schizophrenia lecture, and it gets back to this whole issue of polygenicity and pleiotropy. So the polygenicity shows you how many genes how many variants that they're estimated are involved. So we see 8,000 in bipolar disorder, 5,600 in ADHD, 14,000 in depression, almost 10,000 in schizophrenia. But these genes are pleiotropic because they overlap so much. Look at bipolar disorder and schizophrenia. Almost a perfect overlap. That doesn't mean bipolar disorder and schizophrenia are the same, but it means the genes that convey the risk for those disorders are the same. And it's strongly so for bipolar and depression. And this just reiterates what we saw in the genetics lecture, where there are genes for psychiatric disorder in general, and then they fall into those 5 major subgroups that we talked about, and schizophrenia and bipolar disorder are one major subgroup, and that's clearly shown here. Now, these so-called volcano plots here simply mean that the red genes, if you get one of those, you're going to get schizophrenia and bipolar disorder. They push in the same direction. The blue, they push in the opposite direction. You get either schizophrenia or bipolar, but not both if you get one of the blue variants. Now here with gray matter, schizophrenia and bipolar are very similar in the areas that are involved. It's fairly extensive, worse in schizophrenia. And here you see bipolar versus controls at the subcortical level. The hippocampus is reduced relative to controls. Of course, it's reduced in depression. And oddly enough, it's also reduced in ADHD. So, although not to the same degree. So again, this shows us how we can use gray matter volume more as a general measure of brain integrity rather than something that's specific to a given disorder. And again, the areas that modulate mood in bipolar are not different from those that are in depression. That's kind of bothered us for quite a while, but it's true. So normally your salience network and your frontal mechanisms, both frontal executive network and default mode, are regulating your hippocampus and amygdala. Whereas in bipolar disorder, we get hyperactivation of orbitofrontal and ventral lateral prefrontal cortex with overactivation of the amygdala. You can't look at a fMRI scan and tell whether someone is bipolar manic, bipolar depressed, or major depressive disorder. The same mood regulatory circuits are involved. All right. So in this article, in the book, I discuss these themes. This is a favorite Prite question, but it remains true after 10 years. So you can see the ventrolateral prefrontal cortex is disturbed when you're trying to process emotion. The amygdala and medial prefrontal cortex are disturbed when you're dealing with positive emotional stimuli. You get increased amygdala activation in non-emotional cognitive tasks where you normally wouldn't expect the amygdala to be particularly concerned. Of course, people with bipolar emotionally charge a lot of stuff what they do, even if it's taking out the trash. Then finally, the other theme is the ventral prefrontal cortex activity in terms of abnormalities during reward processing. And these are the structural findings, which are kind of summarized by, generally, having bipolar disorder is not good for either brain, white matter or gray matter, and you get probably both things that are present at the beginning, but there's a lot of scarring. That is, the more manic or depressive episodes an individual has, the more structural abnormalities you are likely to find. Thus, people are sometimes nowadays with this thing about de-prescribing and we got to get people off medicines. Well, we got to be careful about that. And we got to push back against this. Medicines are bad, they're toxic, we got to get people off them. Yes, we should get people off them if it's helpful, but we got to bear in mind that they often have neurotropic effects, as I showed you earlier. All right, and speaking of neurotropic effects. So here we're looking at, that looks like a functional MRI study. This is actually a volumetric study, and this is patients on lithium. What does lithium do? It increases the volume of the subgenual PFC, or ACC is it more properly called. Well, that's great because that's one of the key nodes, as we've seen in affective disorder. Up here you can see bipolar with lithium. There it is, higher. And over here, this is bipolar with lithium versus controls. Blue is bad here, and it goes without saying. Not being on lithium, being off your lithium, we see these atopic, tropic, or gray matter reducing effects. Now, Robert M. Post, the guy must be 120 years old, I don't know, but he has an editorial where he once again, as he's been saying for the last 60 years, that we got to use more lithium, guys. Use more lithium. Well, I'd love to use more lithium, but as you probably have found, that there are a lot of people that just don't tolerate it. Well, first of all, they won't come back and get the blood levels, or they muck around with their lithium and get toxic, or they come back and say, I pee too much, I'm too thirsty, I feel all woozy. So it's an eternal debate. But yes, we probably don't turn to lithium as much as we should. I tell myself that, and then I go to I just put a guy on lithium last week, just stopped him because he had some kind of weird paradoxical reaction. And that does happen with lithium. You got to admit it. All right, this describes everything I just told you. And these are different network activities. You say, well, this looks a lot like what we saw in MDD. Yes, that's true. And you want to think of how these networks work flexibly. So here we're looking at within network connectivity. How do the nodes of the different networks talk to each other? And we'll notice that in bipolar we have the anterior and posterior nodes tend to be hypoconnected. Same with the central network and the salience network. What the hell's going on here? We got a lot of low connectivity within the salience network. And then when we look at between networks, what we're seeing is an overconnection of the salience to the default mode. Maybe that's again that you're overly internally focused. We get less, and the salience network is also pulling things away from the executive network. And then again, the default mode and the central network are also appear to be disconnected. And there we go. All right. So that we will come back to bipolar again as we talk about schizophrenia to address this issue of how closely the two disorders are linked. Thank you very much.